management of centricity, in particular the upgrades and whatnot. We're going to do a little bit of discussion about meaningful use, attestation challenges, UDS challenges, and then just to keep you all on to the very end of the call, we'll talk about the cool new stuff at the end. Like Holly said, we love to make this as interactive as possible, and to the extent that you would like to raise your hand, please don't hesitate, and we will unmute folks and or go ahead and let folks share their experiences. Your experiences on the front lines with this system is incredibly valuable, and I can't emphasize enough how much we all learn from each other's experiences. So the first thing to talk about is the version 12.0, Service Pack 13. I reached out to both GE and to the VAR virtual officeware about this, and got feedback that all of the virtual officeware customers that are up and running on version 12.0 Service Pack 13 are having a good experience. GE reports 287 customers that are up and running on this version with no significant issues identified, and their call volume around it has been reasonable. So that's the experience with 12.0. 12.2 or 9.10. So for those of you who are on the standalone EHR version, that would be 9.10. For those of you who are on Centricity Practice Management and EMR combined, that's version 12.2. And that is now available in general availability. There are 88 customers up and running on this version according to GE. There are two important issues that are impacting some workflow. One is around the review of prescriptions and orders by delegates, and they have a published workaround for that, which we're happy to help you find or share with you if anybody is concerned about that or in that situation. And then there is another issue that is involving bulk payment, and sort of if all of the stars align and you don't use the workaround in that particular situation, and it really only has to do with those claims that are being eventually dropped to paper. It is not affecting any electronic claims, but there is the potential of a HIPAA violation in those situations in this service pack or in this update. So I want you to be aware of that. Virtual Officeware reports that none of their customers are using the workflow that would put them at risk. My hunch is that most of you are not in that scenario, but if you want that information, we can certainly help you with that and provide it for you. Both of these small issues will be fixed in a service pack. So, 12.2 with the service pack on it. So that's slated to be released in February. So I see there are some of you who would like to take a look at that workflow, and we'll make sure we share it out to you. Okay, so that's the version, and it's only with the upgrade to version 12.2. So if you're not on 12.2, you're not in any danger of having these problems. But in preparation for upgrading to 12.2, you will probably want to take a look at them. So before I move on, does anybody want to raise their hand? Anybody have any questions about that, about those updates? Mm-hmm. And as always, we strongly recommend that you stay up to date as possible with the versions of the system. Often, some of the things that you are struggling with are being fixed through these updates. And if anybody would like to have some assistance around developing a work plan or a project plan around the updates, we're available to help with that sort of thing.
Deb, I'm going to pause you here for just 1 second. It looks like Sherry had a question or a comment. Sherry, I've unmuted you.
It's more of just a comment. We've been testing 12.2 in a dev environment for a couple months now in great detail. And we've identified a few issues with how the CCC forms function with some of the new characteristics that have been brought to virtual, hence GE's attention. And we won't be doing anything until we get some resolution there. We wouldn't be able to switch over with as big as we are with a couple of the things that we've seen yet to that version.
And you shared that information with virtual, Sherry?
Yeah, we have calls weekly with them on what we're finding. Okay, because it would be good to know which forms were affected, because not everybody uses all the CCC forms. I know, yeah. If you can
such a lot of variability.
On, and I can next door here and see if we have one trainer that really is analyzing this inside and out, and he could give us a little more insight on that. I just can't off the top of my head come up with the items right now.
Okie doke. Well, to the extent that and if there's any documentation around that, it would be extremely helpful. I can also reach out to virtual about it. They did not mention that when I spoke to them on Tuesday.
Yeah. I'll check with him and get a quick summary before the call's over. I can pop back in later and tell you.
That's above and beyond. I appreciate that.
No problem.
Okay. So the one thing I will say that kind of came through loud and clear from both virtual and GE is that people are having more system stability, better system performance, and fewer issues of getting kicked off, fewer problems with actual database errors, that kind of thing. So they are reporting, or the customers are reporting a more stable environment. Okay. All right. Anybody else before I move on? So why don't we go ahead and run the first poll? First and second poll, Holly?
You guys about 30 seconds to answer the poll, and the following two polls will actually be based on your answer to this question, so just keep that in mind.
We probably should have added an I don't know to that one, Holly.
All right, so it looks like about half of folks have responded, and of those, half say that they have upgraded and half say that they have not.
Right. Okay. So for those of you who have upgraded, now I've lost my poll window.
There you go.
Thank you. Oops. I'm sorry, I accidentally closed that, Holly. That was my fault. Can we run it again?
I've never tested that out. Let me try. I don't know that we can.
Okay, I apologize. I just hit the wrong button. I'm wondering if any of you who would just sort of raise your hand if you've had a rough go of it with that upgrade. Okay. I think we can move on. So Holly, I'm going to need your help because for some reason I have lost my polling my polling window, so I can't see what the polls are. So I apologize, but it's gone from my screen, from my dashboard. Okay, so we're going to move on here. So meaningful use for your, you'll be using the 2014 certified version for attestation with 2015 data, or I'm sorry, 2016 data. It gets very confusing because of the way that the LNC uses dates and the way that this program is structured. The ONC 2015 version, certified version, which will be CPS version 12.3 and EHR 9.12, is planned for limited availability release in April and general availability in June of 2017. So you should plan to be live on 12.3 or 9.12 before January of 2018 in order to be able to qualify for attestation. Does that make sense to everybody? So the 2014 certified version is what you'll use right now. And when you go to attest in 2018, you are going to need to be live on 12.3 or 9.2. Okay. So this is a busy slide, and obviously we will give you all these slides. But the takeaway from this is that if you have any questions about the regulations, you can get to it through this link. Please be careful. When you just put in meaningful use standards, you get some old websites that do not have the most up-to-date, accurate information. So I included this because this is the most up-to-date version of the regulations, of the requirements, so that you are, operating from the right place. The CQMs you are allowed to complete the CQMs from previous years based on your EHR certification. So what you're being asked to do is to complete your CQM attestation to the best of your ability if you've got an older version of the system. I don't think that applies to anybody on this call, and if anybody has any specific questions about that, please let us know. Okay. I'll get to Sherry's comments in a minute. So regarding those CCC forms. At this time, there's still the exclusion for public health reporting because Pennsylvania is not ready to take on any new folks. So you are still excluded from that. One thing I will say, this next bullet is really important. If you have not revalidated your Promise account recently, in the last 5 years, your applications may be automatically aborted. So the folks at the state are really urging all providers to go in and double check and make sure that their promise accounts are accurate and complete and in an active status. We also are encouraging you to make a hard copy of your map year application. If it is aborted, you'll have to start it from the beginning, and we certainly don't want you to have to do that. Please make a copy of it before you leave that site. If you have any questions or concerns, you can send a communication to the email address on the screen, and that will be available to you in this recording. As Holly is stating in the chat window there, we will be reaching out to each of you to help you, again, with your meaningful use and address any specific questions or concerns that you have. Some of these things are general to meaningful use. Some of them are specific to centricity. You do have, for meaningful use this year, you can use a continuous 90-day period. It does not need to be on a specific quarter, and you do not need to use the same 90-day period for all of your providers. But that said, your CQM reports must be for the full year of 2016 data, but please keep in mind that at this moment there are no thresholds for that CQM data that's coming out of the EMR for the purposes of meaningful use. So don't get too hung up on what your performance is on those measures. It's just that those measures do need to be reported for a continuous year. Okay. Some of the deadlines to be worried about. You can start a testing now for your 2016 EHR reporting period. The Map Your site is open and available. The deadline for attestation has been extended to May 31st of this year, which includes anybody who is signing up for AIU. So that was a March 30th deadline, and now it is a May 31st deadline. So you have a couple more months to work on that. However, if you still have 2015 applications pending, you will not be able to complete your 2016 applications. So this deadline has been extended to ensure that you have time to submit and make sure that all of those 2015 applications are done. Okay. We just talked about that important date of May 31st, and then you must, as of October 14th of last year, you must submit all supporting documentation at the point in time that you are doing your application, that you are doing your attestation. So if anybody is having any difficulty with that, that's another area to consider as you're going through this and preparing what that supporting documentation will be for each application, as well as what you're going to use for your organization at the organizational level. So at this moment, I think we will go ahead and talk about just a couple of challenges with MU, and then from there we'll do another poll. So the one of the questions that came through as I reached out to some of you regarding what you'd like to see included on this discussion today is this issue of clinical decision support. I believe that most, if not all of you, have got I2I, and there's some question about how do you align what's being presented in Centricity with what with the protocols that you're building in I2I. And this is an individual decision by organization, obviously, but for many of you, the clinical decision support that's built into the EHR, the protocols that you've built in Centricity, predate the work that you've done in I2I. And creating some alignment there is a reasonable goal. And remember that the clinical decision support that exists in Centricity is there at the point of care while the provider is delivering that care, while the provider is interacting with that patient. So it's a little bit of a different focus. Those protocols built in I2I are really designed to assist with the pre-visit planning that you're doing as you're preparing to meet with patients. It's really designed to look at those areas or to when you're working with patients in between visits, whereas the clinical decision support that's built into Centricity is meant to be happening right at the point of care. I think less is more. That's my bias around this. And where I've seen this successful is really paring down those protocols in Centricity so that you're not being bombarded with pop-ups, because providers really do begin to ignore those, as many of you are well aware. So what I like to do is move those protocols into a spreadsheet so that I have a master that's outside of Centricity so I can see what all the protocols are that are built. Think about how we could be using clinical decision support to drive the QI plan. So there should be discussion happening at your QI meetings around, okay, this is an area of focus for us this year. We have I2I at our disposal. We have Centricity at our disposal. How can we use each of these to help us move forward in this particular area of reporting? Again, if any of you would like to have some, at the elbow time to take a look at some of that, we're happy to do it. But where I've been the most successful is managing those protocols in Centricity in a spreadsheet outside of it with some sort of clear documentation as to why we're building what we're building and what we're trying to accomplish with that, so that we are not bombarding providers with alerts and reminders, and that they don't get fatigued by looking at those. So if anybody has any specific challenges that they'd like to talk about regarding the use of clinical decision support, you do need 5 for meaningful use. And again, I recommend that you pick 5 that are at the, that killed as many birds with one stone as possible. Something that meets your requirements for patients at a medical home, meaningful use, and any other QI programs that you're working with. Think about where you can get a 3 for each of those protocols. Anybody else? Anybody want to talk specifically about their challenges around this? Protocols in Centricity are not easy, and it's easy for them to be sort of get out of date and become the house that Jack built. So if you're feeling stressed about this, you're not alone. Okay. So another challenge continues to be that of health information exchange. We talked about this at our last user group meeting, and that it continues to be a challenge. I was asked to include some information about the various products that are and what people's experiences have been with those. So it looks like, Emily, you may have raised your hand to talk specifically about the transition of care situation.
No, we don't have any hands raised right now.
Okay. I thought I saw her hand go up for a second. So I did reach out to some of you, and Stuart Allen from Esperanza got back to me. The folks at Esperanza are using the Cuvera Transition and Care module, and Stuart, I'm wondering if you would be willing to share your experience with that with the rest of the group. Can you unmute Stuart for me?
Stuart, I've unmuted you, so go ahead. There you go. Sorry about that.
There we go. Thank you. Yes, so we, for the last quarter of 2016, spent the majority of that quarter actually manually sending out TOCs by having a small group of our staff looking at all of the folks that are unmet in our numerator within CQR for the Objective 5 measure, and then going through and actually creating direct addresses to the specialists and sending them out that way. We ran into an issue where there was an issue within CQR where the JSON file in some way was not sending with the referral, and so it was not being counted towards our CQR numbers, and so our numbers were kind of off for about a month. We worked with GE and got our data re-imported and made a few other changes to get that cleaned up. And so now all of our data is correct. And just in mid-December, we were able to finally get the Cuvera piece finally installed for all outbound TOC requests or referrals that we sent out. So far, it's working very well. We need to internally go in and clean up our external provider table to ensure that they are up to date. We are going to need to do another training with our staff about this. And one of the hiccups we're probably expecting to find is that not all of the providers that we refer to have a direct address yet, and if they do, it's not listed through HSX or some of the other directories that we use to look them up. So our staff are going to have to, kind of pick and choose or know in advance which hospitals or providers they can use for sending out an electronic TOC versus having just to hand the information to the patient before the patient leaves. So I'm sure I'm going to get some flack from that. But the technical part of it, as far as outbound messages, are working very well right now. And all of our providers, except for one pediatrician so far, have met the 10% requirement for the last quarter of 2016. Inbound, we're still having a little bit of an issue. The inbound messages are having a technical glitch when they come in. We are receiving them, but they're not getting properly mapped to the right patient chart at this time. So we're working with Cuvera and GE engineers to get that resolved, and hopefully we'll have it resolved next week.
And Stuart, just point of clarification, that mapping is on the Cuvera within the Cuvera module. That's where the struggle is, correct?
That is correct. Yes.
Okay. Can you talk a little bit about you are not using the zip code search functionality in Cuvera. Is that correct?
That is correct. We are not at this point yet where we have seen the actual Cuvera forms. So for our outbound TOCs, we're just putting in the order and saying create a TOC and save it to charts. And from there,
Okay.
Cubera picks it up in the background on a every 15-minute basis or something and sends those out. But we're not actually interfacing with a Cubera form yet that looks up the providers by any kind of direct address or zip code.
Okay. So it sounds like, and Sherry just shared from PHN, that they've been using the Cubera module since November. She agrees also that it's working quite well, although they're not having any inbound issues. But their challenge is finding direct addresses for all referral service providers. And you're managing those tables on your own. Do I have that right? Managing that service provider table yourselves.
Stuart said that yes, they are at Esperanza.
Okay, great.
It looks like everybody.
Okay, so
yes.
Okay, that's a challenge that I think everybody is facing. Okay. So this is good information because I think we can push this direct message or this direct address situation and the directory of addresses. And I will do some further research because I thought that through MedAllies, Cubera was offering a directory that is zip code driven and would allow for a full search feature within it's in the process of doing TOC, which may or may not, I don't know that it would help with this direct address issue, and I just am curious to know how that might be functioning. Okay. I'm also attending a health information exchange call immediately following this. So this is very good information to take to them. Okay. Some other meaningful use challenges, and we talked about these also at our last meeting, continue to be that patient-specific electronic education resource and the use of the TrueVin database within Centricity. Unfortunately, that is the way that you'll get credit for this, and you need to, but again, fortunately, the threshold is very low. So you just need to be doing this for 10%. I think Emily has shared that this is an area that HCCN is struggling, and I don't know if any of you have if anybody has a secret sauce or has licked this issue or are doing pretty well with it, we'd love to hear from you. And Sherry just shared that the MedAllies functionality is available, but the same issue is plaguing us, and that is whether or not we have an organizational direct address or the individual provider. And I would imagine that for most of you, you want to be referring to the practice, not to an individual provider. And having that practice level direct address available continues to plague this HIE issue. And I think we just have to keep talking about it so that we can get the powers that be to understand what needs to change in order to improve this situation around knowing what the direct address is. Okay, moving on to Objective 8, which also seems to be a bit of a sticky wicket, and that is that the patients have the ability to view, online, download, and transmit their health information within 4 business days. You need to have 50% of the patients for each eligible provider enrolled in the portal. And I think that developing some sort of mechanism that automatically enrolls the patient in the portal or allows patients to just opt out of the portal is a helpful one. Again, it depends on which portal you're using as to what the functionality of each one of those portals are. Unfortunately, there is not standardization across Centricity that everybody's using the same portal. And we're, again, happy to help you with some workflow suggestions around that to get you to meet that measure. And then once you've got the patients enrolled, you just need one patient per provider to go in and view, download, or transmit their health information. My recommendation is to do that in the office, to actually have the patient log on and do it, and you only need one per provider to do it in the reporting period. So I think, as with the patient there and a captive audience, is the best way to manage that and get that one done. I imagine that's not that causing that much difficulty for you all. What is more difficult is getting this 50% enrollment level. The CQR piece, Stuart alluded to this, that there were some problems with the CQR, and I do recommend that each of you keep a good handle on that CQR reporting and let GE know when you're having problems. Put a support ticket in to get some help with that, because it's not always correct, and if it's looking wrong to you, there very well may be a mapping issue in there or some kind of other glitch that you need specifically done for your specific instance. So at this time, we'll pause and take a poll.
As Deb mentioned, I think we probably should have put an option here for I don't know. I don't know if the folks who are on the line are those responsible for any of the NE reporting or attestations, but I'll give you just a few seconds to respond to this. Let us know where you guys stand in terms of being prepared for meaningful use attestations.
Emily has shared with us that very few of the hospital systems have generic practice level direct addresses, and most of them are provider specific. In the Philadelphia area, it's only Temple and CHOP who have provided department specific direct addresses. So I do think that we need to keep talking about that in order to get what we need in order to make this an effective process.
And Deb, since you can't see the polls, just wanted to let you know, it looks like about 60% of people voted, and of those folks, 3/4 say that more than half of the providers are meeting or exceeding the threshold. So I'm going to assume that the other chunk of folks probably don't know where their providers stand.
Right, right. Okay, well, that's really helpful information, and as Holly mentioned, we will be reaching out to you. Some of you we've reached out to already, but we will continue to reach out and help people. We really want to see you get every nickel that you are owed for the meaningful use participation. Okay, so we still continue to have challenges around the immunization history, if that just is it's an ongoing issue of management, and I know that some of you are using other forms other than the HTML form that's in Centricity. If anybody wants to explore other options for different immunization management form, I encourage you to reach out to either me or Holly, and we'll help connect you with that. There is a cost involved with it. It's a fairly reasonable, low cost, but there is a cost involved with changing out the immunization management form. And as you know, you all need to be connected to the registry in order to qualify for meaningful use. So that's another area that we're continuing to look into. In terms of UDS, other UDS reporting challenges, we continue to hear that collecting information on sexual orientation and gender identity is challenging. I think that this year will not be a big issue since it's the first collection year for this information for UDS. But that said, we again, want to be available to help you in any way we can to help you move this forward. And as we discussed last time, there are both virtual officeware and Visualution's support in your system. Some of you have Visualution, some of you have VOW to collect this information. I can tell you that in talking to some front desk staff, there's a sense that we don't, that this is not necessary information to be collecting all the time because they, quote unquote, know who all the folks are where this applies. So I think perhaps some re-education and discussion about this at a little bit even higher level of why are we collecting it, why is it important, may be useful for your staff. So you are coming up on your deadline for UDS, and we have worked with many of you. We'll continue to reach out to folks and assist in this area as we have in the past. But if there's anything you need in particular, please don't hesitate to sound the alarm and reach out to either Holly or myself, and we will get time scheduled with you to work it through. All right, on to the cool stuff. And I think we may be able to give people some time back today, unless we spend a lot of time on this. But okay, for starters, there is a new functionality that is now will be in general availability in early February, and that is automated electronic medication prior authorization. What that will do for you is it will give you the opportunity to do prior authorization on a medication through it basically is through the SureScripts platform, so that you can do that literally within the context of the visit. And there will be no need to then have a long, exhaustive process after the patient is left to go through that prior authorization process. There is, the feedback on it has been favorable so far. There undoubtedly will be a cost associated with that, but it will be a per provider, relatively low cost. I encourage you guys in the voice of the customer discussions to talk to GE about this sort of nickel and diming that happens. Encourage them to include some of this stuff in your ongoing maintenance and support and not make everything a per provider fee. That can get exhausting to manage that over time. But I think you should look forward to thinking about this in the cases where you are doing a fair amount of that work, because what you're doing right now is costing you in terms of time, energy, and probably a lot of back and forth with the patient if in fact you can't get something authorized. So that's one that you can look forward to, and as soon as that is available in general availability and we have a little more information about it, we'll absolutely let you all know. We don't necessarily have to wait for these user group meetings to communicate when things are moving forward. The Another area that I was asked to specifically talk about is the e-prescribing for controlled substances. So that you must be on the upgrade of 12.2. So that's the one that is currently in general availability, brand new in general availability. The one that I talked about at the beginning, that is about 83 customers are up and running on. It does provide for two-factor authentication using a system called Imprivata. Imprivata is a third-party piece of a plug-in to Centricity, and it does require, again, it is an additional cost, but thinking about what your costs are right now around prescribing narcotics, and my hunch is that we will be mandated into electronic prescribing so that we can keep better track of who's doing what in terms of prescribing patterns. So I think getting prepared for this is a good idea, and it probably should be in your budgets for in the next year or so. This is being primarily used in New York because New York mandated it, and the feedback has been positive so far. Now, of course, I'm getting that from the vendor, not necessarily getting that from the front line, but I did hear it universally from two. So hopefully that is the case. I don't believe that anybody in our user group is using the prescribing for controlled substances yet. Another question that came up as I was preparing for this today is if any of you, and if you would like to raise your hand, I did reach out to some of you, but I did not hear back. If any of you have integrated the Pennsylvania website for controlled substances for prescribing into Centricity, we'd love to hear from you. I've also reached out to the vendors about that and have not heard anything back yet, but I'll continue to bird dog that, and as I get information, let you know. Any feedback, questions about the updates to the medication module before I move on? All right, I think so. It looks like we have a couple of questions. Looks like Stuart, you've built a link to the website into Centricity. I can't tell whether it's PHN or whether it's
that's Sherry from Primary Health Network.
Thank you.
Yep.
Sherry, do you want to shall we unmute you and let us know what your experience has been with that?
Sherry, you can go ahead.
Okay. Hi, Deb. Yeah, this is a real simple little form. I just built it with BFE, and there's two reasons, of course, that they have to document when they look up the controlled substance, and that is when you're prescribing the first time, and secondly, if you are not going to prescribe based on what you found out when you did do the login and checked on that patient. So it's just real simple, but it puts it right into our chart that who checked it, what the result was. There's a comment box. I did have a button on there that would automatically launch the website, and it worked really cool until some of the staff tried to log in. when they would fill in their username and password, it would clear it. Well, we did some research and found out that until we go to 12.2, the version of Internet Explorer that is used is not with CPS through Citrix is not compatible with the state's website. So they still have to actually go out separately until we update to 12.2 to actually go in and log in and check on that. But it works real slick. It's a nice little form. It's real simple.
I'm going to ask the obvious question. Is there any chance I could impose on you to share it?
Oh, sure. Sure. Now, I will tell you that I have it linked to an observation term. I believe it's Michigan drug monitoring site, because there isn't one for Pennsylvania, and I just didn't bother to request one. But that way we can, that's the only observation term that it pulls to, I believe. But that way we can track and find out how many are using it. Because once they check the box, it says, yeah, I, logged into the website, check that box, it goes into the observation term. So, yeah, I'd be glad to share it with you. It's real basic, real simple form.
Well, we appreciate that, and then if anybody is able to use it or wants to build on it, and we can share resources around that, that would be a beautiful thing. If we can help everybody sort of get to the same place on some of the stuff, that's really what that is part of our mission and what we want to see helping everybody with. So,
sure, I shall send you that.
Thank you. Thank you so much. Okay. Moving on, unless there are any other questions about e-prescribing. Okay. Hearing none, then the seamless integration with Epic. The Oregon Clinic project is complete and going well. This is where that seamless integration to and from Epic was actually put into place. It will be available in 2017 to other existing customers. We'll continue to reach out, and as that information becomes available, we'll let you know. But they are looking forward to other inpatient EMR integration in this year. So with Cerner, with Meditech, and with some of the other inpatient systems, there will be direct integration from those systems into Centricity. So it's sort of a belt and suspenders where your health information exchange is concerned, but it's just something to keep an eye on. Some of you do not have the kind of access that you need to an HIE. And I'm not sure if any of those folks are on this call or not, but that does become an issue when you don't have the ability, you don't have a functioning HIE available to you. So I don't know if anybody from Berks is on, for example, but you do have an Epic Hospital right there in Reading, and this would be a solution for you that may be helpful. Okay, any questions about this integration with Epic? Okay, so seeing none, another cool new thing, although I think it's the verdict is still out whether it's cool, is this Payer Provider Connect, which facilitates the sharing of clinical data between payers and providers. I encourage you to take a look at the YouTube. That really kind of goes through a demo of it. If this is something you think you would be interested in and want to think about, then please let us know and we can connect you. The real issue right now is that there's a very limited number of payers who are available in this module. To my knowledge, none of the payers that we typically see in our health centers are available through the Payer Provider Connect. So, but I just want you to know it is available, that people are beginning to use it, and it's particularly the larger clinics, and to my knowledge, nobody in our area. Advanced orders. Somebody asked me to give an update on Project North Star. They consider Payer Provider Connect to be the first module available in Project North Star. So I'll leave that to you guys, because that is I think that's very limited in terms of the ability to use it. The advanced orders is due to be released in limited availability in Q2 and general availability sometime in the summer or fall. My hunch is it'll be later than sooner. And that will change the way that people are doing orders. I will stay very much in touch with this so that we can provide some support and advisement in terms of workflow, because I think it is going to change the workflow significantly for providers. It should make it easier. That's the goal. But you know, the verdict is still out, and I will be attending the user group in Boston in May, where I'm sure that this will be further discussed and demonstrated. So stay tuned on that, but so far they are on track for a 2017 release of that second module for Project North Star. I want to talk a little bit about Hosted Claims Manager. It's come to my attention that some of you are using Hosted Claims Manager, many of you are not. And for those of you, and I think Sherry can probably speak to this, for those of you who are doing institutional claims, meaning you're sending a claim at the level of your organization as opposed to individual facilities or providers, there is a glitch in the Hosted Claims Manager to be able for you to be able to use it effectively. So we are going to need to stay on top of that. And if any of you are thinking about it, I know some of you who have it, some of you are thinking about it, that we need to stay on top of that to make sure that you're going to be able to use it appropriately. My understanding is there's an expected fix on this in the very near term. However, you know, we've heard that from vendors before, so I remain a little bit skeptical about having something very, very soon, but I would imagine before the end of the year for sure that this will get addressed. It used to be that none of the FQHCs were even considering Hosted Claims Manager, but now that you're receiving your payment on your PPS rate at the point of the claim rather than at the end of the quarter, it's becoming much more popular, a much more popular and useful tool. Okay. Lastly, I wanted to just make sure everybody knows that the Centricity user group meeting will be May 17th through the 20th in Boston. The early registration ends on the 15th, which is fast approaching. And if you want to see the details of that, you can go to this website and get the agenda and the registration information. There is a $200 savings if you register before midnight on the 15th. To the extent that we want to consider any kind of group, you know, more of a group discount, folks should let me know. I'm certainly willing to see what we can put together. Go ahead and get folks registered. I do strongly encourage attendance of at least one of the members of your team to the CHUG. Yeah, and there is that group discount. So, do you want to run the last poll or the last two polls? Holly, I apologize. I didn't give you time before I switched to the user group.
looks like more than 2/3 of folks voted, and 75% of those said that yes, they are sending at least one person to Chug this year or plan to. 25% no.
So if we could, Holly, maybe try to gather who's going so that we can plan to, meet up while we're there, I think that would be really helpful and useful, and it's often good to talk in the context of our group meetings. So let's try to stay a little bit connected around that so that we can maximize our and maybe maximize our messaging to the vendor.
If the folks who responded to that saying that yes, they do plan on sending somebody, if you guys just want to put a message into to me in the chat box so I can keep track of who's planning on attending, that would be great.
Awesome. And did we run the poll about the cool stuff that people were perhaps interested in, or?
I will pull that up now.
Thank you.
Last poll, here we go. All right, so it looks like most people are interested in e-prescribing of controlled substances. 75% of people said that they're interested in that. And then 25% said they're interested each in the Provider Payer Connect and then the automated electronic medication prior authorization.
Okay. Okay, great. So just to reiterate, the first step in that e-prescribing of controlled substances is to plan your upgrade to 12.2. We can get you some information on Imprivata in terms of the cost associated with that. I don't know if there'll be any negotiating capacity around that cost if, we look at it from, the HCCN participants. There may be, and get that planned into your budgets coming up. It does involve, the Imprivata piece involves a token, and that token can either be a physical token that is carried around with the provider, or it can be launched on your mobile phone, so that what happens is when you are getting ready to prescribe a controlled substance, it provides you with a secondary authentication code that has to get inputted into the system in order for that to go across electronically. And that code is produced either by the token or by an application on the phone. Don't ask me why, but my understanding is that the application on the phone is more expensive. And I just think it's because it's more convenient. And the token is a cost, but it's less expensive than the application on the phone. So that's what Imprivata will do and why it's required. But the first step is to get upgraded. Any final questions, concerns? Anybody has? Holly, am I not seeing anything? Sometimes I can't see it all.
Nope, it looks like we've got everything covered.
Okay, great. Thank you so much for your assistance. Thank you, everyone, for your attention. I'm going to turn it over to Holly now as we end. We'll give you a little bit of time back today. Don't hesitate to stay in touch with us about this, about your system and anything that you have questions about.
All right, thank you, Deb, and thank you everyone for taking the time out to participate today. We really do appreciate your engagement and your comments on the call. I'll be posting the recording of the call and the slides to the HealthFed HCCN project portal if you want to view it afterwards. And after the webinar ends, you'll be asked to complete a very brief survey. It's 3 questions. Just give it a minute to load before you close out of GoToWebinar. If you close the tab or the window, you'll actually not be able to view and complete the survey. So again, we appreciate your feedback. We do use it to inform our calls, and we hope that you guys have a wonderful rest of your afternoon. Take care.